So welcome to Copenhagen and this case where we're going to do a left atrial appendage closure. My name is Lars Sondergaard. I'm here with my two colleagues, Gintas Bilauskas and Ole de Bakker. And I also have Niels Weilstrup, who is our imaging expert, who's going to do eyes in this procedure. So before we start, let's see the case presentation here, the patient we have selected for this. If you can have the slides up, please. Next slide, please. So this is a 76-year-old female. She got normal body size. She got several years of paroxysmal atrial fibrillation, arterial hypertension, and she had bleeding issues during oral anticoagulation. That's why she's here with us today. Next slide. So the lab test revealed a mild anemia, normal renal function, and on echo we saw there was quite a dilated both left and right atrium. Otherwise, it was unremarkable. Next slide. We did, as for all our cases coming forward for left atrial appendage closure, a CT scan, and we use it quite extensively to plan this procedure. And here you first of all can see it's a chicken wing anatomy of the appendage. Next slide. We also, can we have a next slide, please? So what we do use also the CT scan for is where is the optimal size to do the transeptal puncture. And you know, we say that for all patients you should puncture inferior and posteriorly. But in this patient with very large atrium, it actually seems to be better to still go inferior, but go more central in your transeptal puncture. Next slide. We also can use the CT scan to actually measure, just as for TIO procedure, we're just not using one single dimension in echocardiography, but we use a perimeter-derived diameter. And for this patient at the landing zone, it's around 24 millimeter. At the ostium of the left atrial appendage, it's around 26 millimeter. Next slide. This image here shows the CT scan where you see the red line, or the red ring is where the ostium is, and the yellow one is where the landing zone is. So from this you can actually project what is going to be the optimal C-arm projection to have both of these structures within the imaging plane. And you can see here we're going to choose an RAO 31 and a cranial 11 degrees. Next slide. We're going to use the novel Omega device. It was approved last year in Europe, have CE marked. And we have, from the CT scan, created a 3D model of the appendage and tried different sizes of this Omega device and found that the 28 is very good with a compression rate of around 18%. So next slide. So this is the plan. Percutaneously, LAA closure, patient is fully awake under local anesthesia. It will be guided by intercardiac echo. We're going to use an Omega device, 28 millimeter. Next slide. This is just a short animation how it works. So you form first a lobe and then you push it in. So it is configured into a cup, which is going to actually conform and self-center in the appendage. And then next you form a disc, which is going to seal off for the ostium. So with this, Niels, maybe I can ask you to show what you can see on the eyes before we get started here.
Yes, we have the eyes probe in the right atrial appendage looking up towards the SVC. And if you see my pictures, I've put a small green cross in the SVC. So this is up, and this is superior part of the septum, and down here is inferior. Now, the difficult thing is to do both perpendicular views, and in this case, you turn your probe into the tricuspid valve, and now you see the aorta coming into view, which means that now the cross is in the anterior part of the septum, and this is the posterior part of the septum. And this is where we want to cross. But during the puncture, I'll go back to this view and watch for the needle to come down through the SVC and tent onto the septum.
Yeah. So let's get ready for the transeptal puncture. Maybe you can tell us, Ole, what you have done so far.
Okay. Yes, so in the groin we have where Niels is working on the left-sided venous femoral, and this is a 10 French sheet, 35 centimeters long. So the eyes catheter fits in there. We also made a venous puncture on the right-hand side, of course, and this is just a transeptal sheet, okay?
Yeah.
And then I have also a 6 French radial sheet. It's not absolutely obligatory, but we like to have it. It gives an extra alignment of the aorta for transeptal puncture. It gives extra possibility to have a nice pressure tracing, and in quite some cases we also use it because it for our alignment with our fusion imaging.
Yeah.
Yeah. Okay, so now we just actually pushed up this transeptal sheet into the SVC. So let's give me a syringe maybe. And, yep. So then we're going for the transeptal puncture. Yep. Yep. Okay. Good.
And again, of course, doing this ICE-guided, you don't need to transesophageal echo, which in most institutions, include this institution, also mean that the patient needs to be under general anesthesia.
Okay, so I have one finger here in between. I have the flush port and the arrow pointing to roughly 4 or 5 o'clock. And then I ask the ICE operator if he's ready for his view. Yeah.
I'm ready.
Yeah, okay, good. Then I come slowly down.
Yeah. So again, if you look at the ICE images, what you see on the top right-hand side is the SVC, and towards the left top is the IVC. So coming down from superior towards a more inferior position. And you see this thick septum secundum. You see the transeptal sheet is just sliding in that, and in a minute it's going to jump into the...
There's stenting.
Into the...
You can go to an REO view also. Yeah, so there's stenting.
So
okay.
this is in the middle of the septum.
Yeah.
Yeah, okay, that's good. Then we want to go also inferior. So push the table a tiny bit maybe. Yeah, okay. So the question is, can we go more inferior? We like always to go as inferior in a way as possible.
I think you go a bit more inferior.
We can go a little bit more inferior. Okay, let's do that.
That's
yeah,
it.
like that. That's it, I guess.
Yeah. And let's see how it is anterior posterior. So this is a bit posterior. Oh, you went through.
I'm already through, yes.
Yeah.
Yeah. Okay.
So maybe you wanted to go a bit more in the middle, or?
Well, what do you think? Are we too anterior posterior?
I don't think so. I think this is where you normally would like to go through.
It's slightly central posterior, so that's what we also...
Say again?
Unfortunately, it's not possible. It's 5:30. I have to be in the cath lab. Sorry. Yeah.
Again, you can do this.
So you see here, what Ole is doing now is put a safety wire in here, just a coronary wire. So when you introduce the needle into the left atrium, it's only a safety measure, not to cause any perforation. And then, of course, advance the transeptal sheet across
we should give
the septum.
please.
I think that's okay. We'll keep it there.
Yeah. Okay. Good.
Pull this
Okay.
back. I pulled back the whole thing because that wire is not.
So now there are two ways
hi
in a way.
Everyone.
to...
Hi, Lars.
Sorry.
Hi, Roxana.
I just wanted to take a quick pause because I want to introduce our new panelist, the director of the courses on here, and we have a great panel. We have Nicholas Van Meegen, Holger Thiel, and Azim Latib, all 3 experts in left atrial appendage closures, and this was a beautiful demonstration of the use of ICE. I think what you guys have done, Niels and Ole, very, very nicely demonstrate the use of ICE. Here in the United States, for the most part, we are using transesophageal echo. Now, more and more incorporating ICE. Of course, it would be a fantastic step forward with no need for general anesthesia. I want to hear from the panelists just quickly, if it's okay, but let us know if you want to show us the device first, and then we can go to the closure. Whatever you like. We don't want to disturb your flow, Lars. Let us know if it's okay. I wanted to just discuss a little bit amongst the panelists about what they're using for pre-planning and intra-procedural imaging. Is that okay, Lars?
Yes, sure.
I want to make sure we're okay with that. Excellent, great. So let's start with you, Azim. What's your thought about the planning of this case, which is so beautiful? I think this is futuristic, a new device, a whole new way of treating patients with left atrial appendage closure.
Yeah, I think they clearly did really detailed planning to use a combination of CT plus also 3D printing to better understand the anatomy is really state-of-the-art planning, and you couldn't do better. I think in most centers, like you say, it's still TE guided without pre-CT, and using the TE for sizing, for the procedure, procedural implantation and evaluating the result. However, more and more, I think we should be moving to ICE, particularly the interventional cardiologists who want to keep their patients awake are moving to ICE. And my suggestion, I think what will help grow this field is having 3D ICE catheters, because they really will give us really better imaging in a 3D way of the appendage to really make better measurements. Until then, I think if you're going to do ICE guided, I like the fact of doing a CT beforehand to also get a really better assessment, one, of your transeptal puncture, where you should do it, and two, of sizing.
I mean, this was a gorgeous demonstration, and now we're even moving to 4D CT ICE to evaluate these things. It's very, very interesting. Maybe I can have Holger. I know you have to leave us in a few minutes. How are you guys approaching these in Leipzig? And then we'll go back to Lars.
So we do not do CTs in all the patients, only in very selected patients. So usually we just use TOE, and by this we do the sizing. We do it during the procedure. Usually, and maybe this is also important, we do not use general anesthesia. We just need, we are using conscious sedation, and with conscious sedation in the cath lab, you can easily do a left atrial appendage closure. And usually these patients are directly transferred to the normal ward after the closure of the left atrial appendage, and usually we discharge the patient on the next day. So this is easily be done. I'm not sure. It's nice to see it, but I'm not sure if really general CT imaging before is really required, and I don't think that we will really improve the outcome and also maybe the procedural results by using CT. It's nice, and it's also nice to have 3D printing, but I think for the majority of patients, it's easily be done with TOE.
Lars, respond before you leave us, Holger. Lars, what do you think about Holger's thoughts about this?
I'm a bit surprised because when you see a CT scan, you see how different these morphology is, and there's small side lobes and so on. You can miss on the echocardiography. And all of us who is doing TIO procedure would never do a TIO procedure if you didn't have a CT scan before. So I think it's a small request to have a CT scan before, and it gives you so much information about and will optimize your procedure. But I know it's different from country to country what the tradition is, and I'm sure that skilled operators like Holger can do this on an echocardiography, but also think that most of these cases around the world are done by operators who are not as skilled, and I think a CT scan for those cases will improve both the safety and the efficacy.
Well, take us through your deployment.
Yeah. So first we want to see, because when you use ICE, you get the far best images if you have your ICE probe in the left atrium. We only use one single puncture. So if you can see, go back to fluoroscopy and see that here. You see we crossed the septum. We now have a stiff guide wire in the upper left pulmonary vein. The delivery sheet is across, used to dilate the septum, and now Ole is going to pull, pulling the sheet back, and Niels is going to track on the guide wire the ICE probe into the left atrium, like this. So it's only one single puncture of the septum. And then again, Ole is re-advancing the sheet into the left atrium.
You have that piece, white piece? Ready? Wait, I'm going to push it.
So take us through what you're doing right now. So the ICE is right there. I see it. And you're just across, I see, and I want to see where the cup is and how you're positioning the cup. And show us that, yeah, I see the left atrial appendage here on the left. Excellent.
Yeah, but we can exactly. So now we have the sheet into the left atrium and also the ICE probe. Next thing is of course to engage the left atrial appendage, and to do that in a safe way, we're going to use a pigtail to actually go in and then track the delivery sheet over the pigtail afterwards. So what Ole is doing now is he have a wire connector here to make sure that it's not bleeding out as we're doing. We take a pigtail catheter with with a standard guide wire
Just a 6 French. Yeah.
and introduce it into the delivery sheet here.
Yeah. Okay.
And then introduce the pigtail up to the tip of this introducer sheet. And in the meantime, you can see Niels is now has placed his ice probe in the upper left pulmonary vein and is looking down to the left atrial appendage. Here you can actually see in the bottom, you see the circumflex artery, which of course is a landmark when you do your deployment. So Niels can follow us. As you see in a second, you see the pigtail will come out of the delivery sheet and like this, and we try to steer it into the left atrial appendage. And you see nicely on Niels' images, I think we are, what do you think, Niels? Is it in?
Yeah, there it is, yeah.
Yeah.
Okay, we're also
There
in the
it is.
implantation
I
view
could
now.
see
Yeah.
it almost.
Yeah. So now over this pigtail with the standard wire inside but not outside the pigtail, we now slowly advance the delivery sheet forward very carefully because, of course, it's a paper-thin wall of this left atrial appendage, so you should be careful not to have any perforation. And when this is in place, we're ready to take the device and do it. First, here we take some contrast just to confirm that we are in the right position with the delivery sheet. Again, you saw we went to this RAO 30, cranial 10 degrees. This is where we get the best view of both the landing zone and the orifice of the left atrial appendage. So let's do an injection here and see
Okay, I'm ready.
where we are.
Okay, okay.
So you see this chicken wing anatomy. And I think from the 3D model, what we could see, Ole, was that we want to implant it a little bit deep to have the best compression rate and also separations to the disc, so the disc is actually have concavity and is going to seal off. So what Gintes is doing now, he's getting the device itself. It's loaded here, and
Go a little bit deeper.
we go a little bit deeper first with the sheet. As I said, we want to have a little bit deeper implantation, and always advance this over the pigtail catheter. Don't go
Pull back.
without. So we take the pigtail catheter with the standard J wire out.
Yeah, let it bleed back.
We take the white tube off, let it bleed back, make sure there's no air in it. And then on the cable, we push the device forward.
So Niels on ice, how deep are we there with the... Okay,
So
we're
you're
not
just
very
not
deep.
too deep.
No.
And then you
Yeah.
see here in a second, now you see the device is approaching the tip of the sheet.
Space to push it.
So go out a bit.
So Ole, you can comment what your strategy is here.
Yeah, so I think we have on ice. We see we have still depth enough to push the ball out. So this is the first configuration, a ball shaped. Yeah, that's enough. Keep it here. And now I think we're gonna give a little bit of contrast to see also on fluoro. And at the same time, we can also look on ice. On ice, it doesn't look like we're very deep in yet.
No.
No. So we
So
can
let's see.
Inside the circumflex.
Yeah, okay, so that's the nice information you get out of the eyes, that you're slightly distal of the circumflex artery.
Just 1 second. We have to
Yeah,
there's
there's some air in.
some air in.
Okay, then it's better to retract it, I think.
How did it? Okay, let's.
Okay.
We have a little bit air in here,
I
I can
think
see.
it's
So,
more
of
safe
course,
to
this is
pull it.
something you have to be very careful about. So otherwise, you open it here, Ole, and let it bleed back.
Device is...
Yeah, but you can open here and
Yep.
take that introducer tube out
Bit
here
on a low
and let it
level.
bleed back. Yeah.
and this one will flush here.
Reconnect here.
Yeah, okay, that's a good solution.
There we go.
And
In that in-between piece.
Oh yeah,
Can we have that?
hold it.
No.
where do we have that?
So it's just a matter of finding the connective part again.
Where did you put the
Here.
Here. Yeah.
So that's absolutely something to avoid. Air in your catheter, you're working on the left atrium. So if that happens, you risk really that air comes in a coronary artery or and can provoke really large ST elevations on the ECG. Okay. Okay, let it still bleed out because it's not flushed here. This.
Can I
You
ask a
can
question?
easily get air into the left atrium, and then it goes in the right coronary artery. So it's good
Exactly.
to show
Exactly. So you really have to be careful.
how pedantic they're being about this.
Okay, I think it's.
So what we did, we
I
took
know that
this
our team is
introducer
ready
out.
in
This was where the
Erasmus,
air
but
was.
we don't want to leave you.
Yeah, we can hopefully implant this in a few minutes. So now we're just going to check
that's
where
fine.
the
We'll stay
depth
with
is
you.
actually is. Yeah.
So we are ready
Okay,
to
we're ready
inject.
to do an injection here and to see where we are.
Okay. Yeah.
Yeah. Okay. Good. So I think
So
we can slightly move it tiny bit forward. I'll do that.
Yeah.
I'll move 2-3
And
millimeters.
it's a very atraumatic device, so you can push the device forward,
I continue out.
Yeah.
and then
We do a combination of pushing out the device and pushing also forward the delivery sheet, actually. And that's something else than you do. You see, that's the maneuver we like to see. Okay, and form it then. Now we unsheath the disc. Okay, yeah, like that. All right, that's it.
so let's go to you first, Niels, and you tell us what you see on ice.
On the ice, you'll see the cup here in the appendage. And then I see the disc that is now covering the Coumadin ridge, so it's exactly where you want it.
Yeah.
I also see a few air bubbles here that is now trapped behind the device. So I think this is in a good position.
Yeah. At least for the amulet device, it's been shown that if the disc is covering the Coumadin ridge, the ridge between the left atrial appendage and the left pulmonary veins, the risk of having device-related thrombosis is much smaller. So that's what we should aim for in these patients. And you did an injection here, Ole. Just what are you seeing here?
Yeah, so things what we like to see on this device is, first of all, I would say compression on the cup. And that's something we absolutely see. Then typically if the cup gets compressed, you get this more rectangular configuration, as you see here. So that's a good thing. Then if it's to see if it's deep enough, well, you can see this also on the fluoro in a way, but it's even better to assess this on the ice. Maybe Niels can show that later, that the cup is at least 2/3 distal of the circumflex artery. You also want to have it nice aligned with the central axis of the LAA, which is the case, and that's almost always the case with this device because it's a self-centering device. And then what I really find reassuring here is that there is some separation between the lobe, the cup and the disc. So that means there is probably enough anchoring in this cup. And then last one, and that's actually the whole purpose why you do this, that you want to see this cup, the disc restoring the concavity of the left atrium very nicely, and it's kind of a nice concavity, small pull into that LA. That's the best guarantee of a complete closure of that LA. So, yeah.
So I think we're pretty happy about this, but
So-
of course very interesting to hear what
looks
you guys
gorgeous.
think about it. Any questions?
Yeah. No, I mean, I think it's a gorgeous demonstration of this device. We have Nicholas online here. And Nicholas, any thoughts about this? My one question to you was, is this if this is a nitinol, I imagine this is nitinol, will this continue to expand to will the cup continue to expand? And what's the risk of compression down the line? And has that been evaluated? One. And then any other questions from the panelists?
I can answer. We haven't seen any issues about it. It should cause any issues with perforation later on. And also, I think you have this. It can also you have this cylindric inside the cup, so I think it also takes some of the pressure off. So again, it has not been an issue for so far.
Okay.
Yeah.
We have done some control CTs even a week after and then 3 months after. What we see is even very quick, a week after that even if you have very elliptical LAs, they become immediately circular with almost all devices. But you still see the compression. It's not that you lose your compression.
Yeah, so I have to go live to Just. This has been amazing, amazing, amazing. Sorry, guys. Maybe we'll come back again. I'm not sure, but we need to go to Erasmus. Sorry, Nicholas. Are you okay if we go to live to an Erasmus?
Sure.
Hello, everybody. Welcome back to Rotterdam. You hear us?
Yeah.
Excellent. So, yeah, welcome.
We hear
we are
you.
here
We're ready for you. Hello.
Hello. Good to hear you. So we are in room 22 here today. So my name is Joost Damen. I'm here together with Wijnand van Dekker, my colleague. We had the nursing staff here, Sanna, Danielle, Martin for the technical backup, and obviously Jurgen Lichthart for the IVIS imaging. So we have quite an interesting case for you selected today, and Wijnand will present the case. But before we do that, I quickly want to show you the result of the very tough marathon that Nicolas and Roberto did yesterday to tackle the anatomy of this very complex case with a very poor LV function, severe three-vessel disease, in which they managed to open up this LAD and large obtuse marginal branch under the support of the PulseCAT system. Excellent result, both on IVIS following the lithoplasty and also angiographically. And without further ado, I think I should give the word to Wijnand to present our case of today.
Yeah, thank you. Also a warm welcome from my side. So today we will use another device to treat the calcium. We will do an orbital atherectomy case. We have selected a 71-year-old male with hypertension and hypercholesterolemia. And he had an inferior MI in the past, for which he was treated with the PCI of the RCA. And in 2015, a MIBI scan showed a persistent perfusion defect inferior. He has a good kidney function, and he was referred to us because of progressive angina. Next slide, please. So this is EKG, which is well, quite unremarkable. He has some extras, negative T in 3 and some small Qs. Next slide. So this is the echocardiography, which shows quite a good LV function, maybe some depressed function inferior, infralateral. Next slide. So this is the coronary angiography. So here you see the right, which is a CTO with some bridging collaterals. You see the stent in the distal RCA. Next slide. And this is the left coronary system, the spider, which shows some calcified, diffusely diseased circumflex. And next slide. And this is the cranial views where you can see the LAD, and you can see clearly the calcified lesion proximal, and also there's a lesion distal. Next slide. So we will use the orbital atherectomy system from CSI, and here you can see the components. You have the pump, the device. We use the Viper Flex wire, which is a nitinol wire with a 0.012 wire with a 0.014 at the tip. And we use the lubricant, and you can appreciate on the right the worker mechanism. So you have a 1.25 crown, which works in an orbital manner. So the slower you go, the bigger the orbital, and you have the differential sending of the calcium, but also you can crack the medial calcium if there is medial calcium. So I will give back the word to Joost to present the setup and the strategy of today.
Excellent. So what we did is actually we started again with a EBU 375 with a right radial approach, 6 French. We made a few angios, and what I quickly want to show you for those who believe, well, the LAD is calcified, but is it significant? So with a angio-based FFR, and Martin maybe can quickly show that to you. So by just exporting 2 orthogonal projections, so in this case a cranial view and an RSO view, in the CAS system, the system automatically detects an end-diastolic frame. Contour correction is very fast, and then you enter the blood pressure, which Martin will do on the spot. At that time it was 124/70. And this system will provide you with an instantaneous physiological assessment of the segment of interest. In this case, the VFR was 0.74. And the cool thing is that if you click on the RSO, you can also get the individual values per segment. And you can see that the drop is clearly in the proximal segment, whereas in the distal segment, the pressure drop is somewhat smaller. So that just show that this is something that might be ending up in your labs as well in the near future. We talked about it more extensively yesterday. But in this case, and then I will open up the case for discussion, we started with a IVIS of the LAD. I think, Wijnand, I dare to say this is part of our routine practice here in Erasmus to treat all these cases virtually with imaging in order to get a better appreciation of the significance of the calcium. So we did a pullback in the LAD, and Jurgen will take you through the calcium and the LAD within this artery.
Yeah, thank you, Joost. So we started distal, and you're going to see that there are two regions with calcium, and this spot here, the vessel is still normal. So if I go more proximal, then this is the first region. You see the calcium here. We have now eccentric superficial calcium in this spot here. The minimal area there was around 3.05. In there, if we go more proximal, again we have a region with a nice normal vessel, which we're in luck, though that gives perspective for later the stent implantation, but that we do after the orbital atherectomy. And then we reach the proximal region of calcium, and here we have this classic napkin of superficial calcium, 360 degrees superficial calcium, and also that will do with orbital atherectomy. And it will be interesting to see later on, if we make a control IVIS, how the device behaves in both the concentric calcified plaque and the eccentric calcified plaque we found more distal. More proximal, we see still some calcification, but more or less than 90 degrees, and it goes up to the ostium of the LAD, and then here we end up in the bifurcation and in the left main stem. So far, so good. Any questions? I
have, this is great. So I wanted to just kind of, just looking at your QFR, I found that it seemed to us that, and please correct us, that maybe just focusing on that proximal large vessel is the way to go. But it sounds like you really want to treat the entire vessel. Can you just expand on that? Is there a need? Is that what you want to do, Joost?
Yeah, so that's a good question. It's actually funny that you mentioned this, because when we started the case, when we were still offline listening to Lars, we were discussing the same thing. So the MLA here is around 2.8, I guess, at the distal part, whereas it's a trio vessel. I mean, if Jurgen goes to a B1 and if you show the IVIS, you can see that this really is a trio vessel. Yes. So again, we were a little bit discussing this, but I think it would be good to treat both lesions, also because of the fact that there is a CTO of the right, and this LAD really is also taking part in providing the inferior and lateral wall, at least for what is left of it, following the MI of blood. So that's why we thought it would be good to treat the full vessel.
No, absolutely. So as you get ready, let's turn to our panelists. Nicholas, yesterday you used IVL. Today we see orbital atherectomy. What do you guys? How do you choose which device in whom?
So this is a patient that was referred to us from another hospital, and then we have the luxury to prepare the case, and then often we decide based on the angio which kind of technology we would want to use up front. But of course, sometimes during the procedure, as you are interrogating the lesion with invasive imaging, you get advanced insights. And I think you could definitely also consider using a shockwave balloon, but you have now a very long segment that you want to tackle. You have a focal circular lesion, and then you have a more eccentric lesion distally. So I would agree with Joost that a more atherectomy device would be more appropriate in this particular setting, because you have you have a very long lesion with multiple segments, and we also are learning how to use orbital atherectomy at this stage in Europe, because we only did the first European case 2 months ago in Erasmus. But apparently you also you not only work on the superficial calcium, but also on the calcium in the media using orbital atherectomy. So this is, I think, an additional advantage of this kind of technology.
There's no question. I think it's a beautiful way.
Elaboration on this issue. So what we would like to do in order to keep the patient not too long waiting, so we have seen the case of Rich Lofnitz yesterday, which was obviously extremely fast, but given the novelty of the technology in Europe, we really wanted to spend a couple of minutes to demonstrate you the device. For those of you, at least in the Western world or in the European world, that are not that familiar with the device. So maybe you, Wijnand, you can just briefly touch upon the basic features of this technology and how we prepare it.
So here is the device itself, and the crown is obviously you can see. You can see here is the 1.25 crown, and so this is a. Sorry, yeah, this is the device. So here is how it comes from the fabric, and then you have here two buttons. One is for your speed, so you have a low speed or a high speed. Well, they say that in most of the cases the low speed is good enough, because you get if you go slow enough, the orbit will be big enough to treat the whole vessel. But sometimes if you have a big vessel, you can also use the high speed, so your orbit may become a little bit bigger. And then this is here you can if you this is the on-off button, and you can also when you enter your guiding or the coronaries, you can use glide assist to reduce the friction. So if you enter the system, you can use glide assist. You can this button is for this. If you push this button for 3 seconds, then it will blink. And if you
you can test it, right? So people can see directly.
Yeah, I don't know if you can hear it, but there is it's only 5,000 RPM, so it's the volume is much lower. So now it's the system is locked, and if you open it, they say wings out. We heard the chicken wing last in the other in Denmark. Here's wings out, and then you can move the button forward and backwards.
Okay. So yeah, that's more or less it. So you load it on the wire, do the testing on the wire. With the Rota, we were used to do the testing in a small bucket of water, but yeah, here you just you can test it on the wire. So the brake is off, glide assist is on, and we go in very gently. Yeah, straight line. Stop.
Device is tremendous. I mean, it really is very much simple to use. We've had it in our lab for a couple of years now, and we use it often. Azim, any comments?
Yeah, I think this is a great case for CSI. I think you could have also used IVL in this case, like Nicholas mentioned. But I like this case for CSI. It's a nice big vessel. It's very straight. I prefer to use CSI when I'm going into sort of a straight vessel. You know, going around a curve or in a very tortuous vessel can be more challenging. So I just think you need to be careful about that. And what we tend to do in this case is, you know, go to the distal lesion, burr the distal lesion and sand the distal lesion, and then move to the proximal lesion and sand that, and not do the area in between. I mean, we used to with Rota just going, starting the Rota and doing the entire area. If there's an area like this, you'd even burr through the area in the middle because you wouldn't touch it. I think with this device, you really wouldn't burn the area where there's no calcium. You try and burn the areas where there's calcium.
So just walk us through what you're doing. Beautiful, exactly.
Yeah, so what we did, so the funny thing about, the good thing about what I like about a lot of this device is the fact that it's very controlled. So the Viper wire lets itself maneuver quite well. And with the glide assist on, you can very easily, only on 5,000 RPM, engage somewhat more distal in the artery, where you can start the orbital or the sanding. So let's do that. So wings out. So why not press the low speed RPM button and we gently start. So the key thing, you can hear the sound, is that you move 1 millimeter per second. So very slow, because only then the orbit will get the chance to really ascend the concentric and the eccentric calcifications. So we go very slow. After 20 seconds, you hear the audible sound, we stop. We typically stop outside the lesion.
Is the very slow, methodical way of going through this lesion, coming back very, very slowly for 20 seconds on the lower speed, as you notice, lower speed.
You hear the sound?
Oh, yes.
Yeah.
So you hear the pitch of the sound going up once the crown starts to touch the calcium. So here it's a relatively short lesion, 10 millimeters. So we did 2 runs back and forth. We'll keep it with that, and then we go proximal, where we obviously probably need to do a little bit more.
Yeah, I agree.
So we put the device again on glide assist, and then Wijnand can take out the device.
And that's a fundamental difference from Rota, that you also deliver therapy as you're coming back. So you send going forward and moving backwards. So that's also of interest, and maybe can also reduce the risk for getting trapped in the calcium.
Mm-hmm.
All right, so we went back with the glide assist to the proximal part of the LAD, and we'll do some other runs here. Patient is very stable. He had some extras, which was already the case, and here it's very nice. So here you can hear the sound.
Yes, we hear the high pitch. Yes, we hear it. We saw the concentric calcium. You're going through and then coming back.
Yeah. We'll stop here. 20 seconds.
The sound of the
Patient
pitch
is again very stable.
lot higher than what it was down below.
Yeah, that's correct. That's correct, which reflects the nature of the calcium, mainly the concentric aspect of the calcium here.
Now here you've got a larger vessel. You could decide to give a little bit of a higher energy, depending on how you feel.
Yeah. Yeah. Yeah, so that's, I have to admit, we're still exploring. Thus far, we restricted to the ourselves to the low speed. But yeah, I agree with you that in large vessels. Alrighty. So what we'll do is that after the orbital, and that I think would be
another. You can keep going if you feel like you haven't done your, how do you feel? How does it feel? How is it moving through?
It feels good, and that is, I think, what we've learned with this device is that, it moves and it tracks very well.
I think an important difference with rotational atherectomy is also that because it's as an orbit, it turns around in the vessel, blood is still flowing through. And this is different from rotational atherectomy, where you completely obstruct the vessel in principle and there is no forward flow. And of course, there might be a higher likelihood of microvascular issues afterwards. So I think this is also basically during a procedure like this, as you are spinning or sanding, if you would give contrast, the contrast would really go all the way down in the vessel.
Right. So let's have a look
Also,
what we
I
did
think
with the imaging.
Showed very nicely the
Go
ahead,
technique is
Azim.
different to rotational. You know, in rotational, we just would burr all the way down. He burred the one lesion, you then came back, you then sanded the other lesion. You didn't touch the area in the middle where, you know, there's no calcium and you could potentially cause a dissection or injury if you touch the area in the middle. So it was a really good technique. Considering you've only been doing this for 2 months, Joost, nicely done.
Oh, really, really nice.
The only thing different we might have done.
So you
just
can
to
see
be more
very simple
comfortable,
coming out.
Yeah. Yeah, so it's quite
is
controlled.
based on what Roxana said, we
so
might have
that's,
gone with
that's
at the
good.
highest speed proximal. Just one run at the end.
Yeah, I suggested that, but I also respect their idea of wanting to take it slow in their early use of this device. But that's probably what we would have done. Go just one run on the higher energy in this larger proximal vessel. But let's see what you got.
You know what? The good thing is this Viper wire is not too bad. We will deliver the IVIS catheter over the Viper wire, and if we're not happy, we can do another run on high speed proximally.
So Azim and
Yeah,
Roxana,
that's the
what
other
is the
thing, you
benefit
know,
of this higher speed?
Yeah.
I think
Well,
when you're in a
look,
larger
So what
the
is the
higher
vessel-
speed.
benefit?
Yeah.
Sorry, Roxana, go ahead.
Well, no, that's okay. We've done a lot of this at our institution. We have probably used more atherectomy than anyone in the U.S. Pretty much regularly. And what we have seen with the higher speed is to just get a better, especially in the larger vessel, better ablation of the calcium and getting a better luminal diameter. So you'll see how this is going to work. I mean, I think Joost did a beautiful job. He was very methodical. Went back and forth several times, and I think he felt, and you're going to see the break of the calcium here as you'll observe on IVIS. It'll be very telling.
So we are in the mid part now.
Come back on that after the
So
pullback.
usually what you would do, I guess, in routine practice, as Richard Slovmans did as well yesterday, is you take a non-compliant balloon immediately, because that's what you, I guess, would do before you proceed to stenting. But since we're really trying to understand the individual benefits of each of the technologies, we like to repeat the pullback directly after the atherectomy in order to better understand the actual effect of the technology. Here you see some dissection, by the way. Some fractures at 12 o'clock. Do you agree, Jurgen?
Yeah, I'll just have a look.
Yeah,
I
also
think
there.
so, but yeah, here definitely.
Yeah.
Here's definitely
Yeah.
at.
So I'm happy
3
because
o'clock.
actually that's the only thing we wanted to achieve, to generate some cracks here and there. And the good thing is that there are no large hematomas, at least non-extending here.
And then
That's great, and
that's
that's we
the
are in the
left
left
main.
main. So I'm actually very happy.
I'll stop here. Joost, you want to do pre-dilatation first?
Yes,
or?
definitely. We will continue with some pre-dilatation.
Yeah.
So if I can have a...
Yeah, then I'd
So you-
suggest that we do the measurement
So Joost-
for sizing after the pre-dilatation.
Yeah, sure, yeah. Please go ahead.
That's perfect. If you don't mind, we're going to go back to, as you do this beautiful work, we're going to go back to Lars.
Please,
we're going to
do
go
so.
back to Copenhagen and come back to you. Thank you, Joost. A wonderful
Excellent,
demonstration
thank
of
you.
orbital atherectomy. Wonderful demonstration. We'll be back. Hey, Lars, can you hear us?
Hi, Roxana. Yeah, we hear you.
Hi. You guys did a beautiful job. Thank you. Sorry for the quick going back. The patient was on the table for a while, but what I want to do is show the results of our poll, which was about in low bleeding risk patients, should left atrial appendage closure be performed. Can you show us the results of the poll, please? Once we see the poll, yeah. So should catheter-based left atrial appendage closure replace oral anticoagulation also in, and the answer is 50-50. So take a look at that. That's pretty, and lots of the people, of course, believe it should. Lars, what do you think?
I think we need to see more evidence on this therapy. I mean, the evidence we have so far is what's supposed to call it a reveal trial and protected AF, but that was against vitamin K antagonist, which no one is using anymore. There's 2 large-scale trials ongoing. Abbott has conducted the Catalyst trial, and Boston Scientific the Champion trial. And they're going to compare left atrial appendage closure against NOAC, which is a contemporary treatment for these patients. So before we have seen these trials conducted and seen the outcome, I think we should stick to what we know for the time being. It should be reserved for patients at high or risk for bleeding, or patient with absolute contraindication for anticoagulation. That's at least my opinion.
Oh, no, I think I'm right with you. Honestly, I feel the same way. I don't think that we have the evidence against NOACs, but certainly seeing that the large randomized trials are underway makes it very, very comforting for me to see that. And I think before we go to the low bleeding risk patients, anytime you have a patient on an oral anticoagulant, though, they're at a high bleeding risk. And I think that's kind of it's a funny situation to say, well, you're at low bleeding risk and you're on an oral anticoagulant. Your bleeding risk is higher. So let's hear from our panelists. Nicholas, what are your thoughts about this before we go, just to wrap up with Lars and the team and why they chose that device over Watchman?
Yeah, well, first of all, I would like to say that what we've seen is we have seen the Champions League of LAA closure here. This team is a team of super experts. They are very good interventionalists, and I was also very intrigued by the involvement of the imager using the ICE catheter, because we are used to, as interventionalists, to be using this ICE catheter, but I do see the added value of the imager controlling the ICE, because then you really have 4 hands and somebody can do the imaging as you are doing or executing your procedure. So I was very intrigued by how they executed this procedure under local anesthesia and ICE guidance. I think this is a lean way of doing LAA closure, and definitely something that I will implement. A part of that, I think I totally agree with Lars and also with you that we do need more randomized trial data to see how this type of mechanical treatment compares to medical therapy with NOAC.
No, there's no question about that. Azim, last thoughts on this before we go to Ole and Niels, because they did such a beautiful job with Lars. Azim?
No, just, great case. For me, it's the first time I see an Omega. In the US, we still only have Watchmen, so it's nice to be able to see a new device. I like the mechanism of this device, of how you kind of push forward to expand it more, to get it to anchor better and really conform to the anatomy. So great demonstration also of using ICE. I certainly would love to see how this procedure evolves when we have 4D ICE catheters readily available.
No, there's no question about it. And Niels and Ole, what a beautiful demonstration. What I loved about your team is this cohesive way of approaching this patient, planning it with CT, the 3D imaging, and then the use of ICE in a totally awake patient, with the delivery of the device so precise into the left atrial appendage, so well planned. Tell us how you got there, and why did you choose this over the Watchman?
Ole.
Yeah, so why specifically this device? Well, I think if you look at the anatomy, it is this device is is really excellent in a chicken wing anatomy, I would say. Because maybe if we can have for just a second of the fluoro on the screen again, is there a possibility for that? to have the fluoro just on, then you can actually appreciate how flexible, yeah, that's excellent. So how flexible the cup and the disc is. So you see that stalk between the cup and the disc, you see that it's an open end at the proximal end. So this makes it that disc and that cup are extremely flexible towards each other. And so that also gives you the possibility to really close this LAA completely to the comedon ridge, which would be harder with a discless device, I would say. And that's why we specifically took this device. As you could see in the initial shots, there were actually trabecularizations very high up, almost at the comedon ridge. So this would be almost impossible, maybe, to close with a single lobe device. So I would say that the fact that it has a disc and an anchoring part, and then this extreme flexibility from cup versus disc in this particular Omega device made it an excellent choice in this patient.
All right, well, and fantastic, really great work. Lars, what are you doing for the antiplatelet regimen? Is there an antiplatelet regimen for this patient, and what happens with their NOAC?
We stop it, and this patient also had the bleeding issues on anticoagulation. So if the patient can tolerate, we give a couple of weeks of dual antiplatelet therapy, and then we continue on aspirin. If the patient had very high bleeding risk, we'll just give a single antiplatelet therapy from the procedure and afterwards. A few patients will actually drop any antiplatelet therapy later on. No.
Okay. Wow. Well, we just can't wait. Well, we want to thank you for the wonderful work that you did, and congratulate you on showing us this new. I've never seen this device before. It's fascinating. Thank you again. Thank you so much.
Thank you. Thank you.
Bye-bye. We'll go back to Erasmus, back to our calcific lesion. Hi, Jus, we're back to you.
Yeah. Hi, welcome back. So we proceeded with a bit of pre-dilatation of the distal part and a proximal part with a 2.5 and 3.0 non-compliant balloon. We stented the distal part based on the IVUS with a 3.018 or Cyro stent. And we are now proceeding with the proximal part, where we also did some pre-dilatation. Based on the IVUS, we decided to put a 4.035 stent. We're now going to do some post-dilatation here with a 4.0 non-compliant balloon. And to quickly check here, and then we'll show you an angiogram and the IVUS. Blazen. 18. 18. Yeah, so we tried to land the, that's the cool thing here about using the IVUS, is that we were able to appreciate the 20 and down, the size of the left main, which was huge. And I think if Jürgen can show you, the left main was, I think, 6 or 6.5 millimeters. So we used the IVUS to see what we could just land here at the ostium of the LAD, which seemed to be feasible.
Yeah. Okay.
And yeah, with that, we hope to be able to avoid left main or complex bifurcation stenting. So we left open the ostium of the circ.
And this
which will then allow us to easily wire that and then see if we can optimize a little bit this proximal part of the circumflex. So that's it. So, well, patient is doing fine.
Shall I take them a bit with the result after orbital, what we saw on the IVUS?
Yeah.
Yes.
We'll also show you, and this is pretty cool. So you see the distal part here of the IVUS, where we did the orbital, where there was eccentric calcification. But even there, you can see very nice crack.
Yeah.
That goes all the way through the media.
It's a wonderful demonstration that this device worked with both eccentric and concentric calcium. Really nice demonstration. Thank you for showing that to us.
Here is the proximal part. So also there we have at 3 o'clock, it's partly blocked by the guide wire, but here we have the crack in the concentric plaque. And definitely In the rest of it, probably we have some cracks, but it's made thinner, and it was good for pre-dilatation.
Can we put the IVUS on live again?
Yes, we do. Just for a moment. There
So
we
I
go.
changed also in the meantime the Viper wire for a standard BMW.
Oh, great. That's great.
So I
we have
always
about
go in-
3 minutes. And, yeah,
Yeah.
go ahead.
Okay.
So we'll quickly do the IVUS run and then give you an angiogram.
Leave it there,
And then I
Joost,
think,
and I'll start pulling back.
You make it nicely on time. Pull back.
Okay, I started already. So it started distal from the distal stent, of course. The septal branch came in from 9 o'clock. And then first we look at the distal stent. Well, I didn't see an edge section. It's nicely round and opposed. And here we still see a bit eccentricity due to the calcium. The crack was small, but it's there. Here's the proximal part. Here we have some malposition in the proximal edge that we're going to attend to.
It was unavoidable. Huh?
Yeah,
I mean,
but
we landed
that
in a
we
very large bit
we
of
saw that already,
charismatic
but
part.
probably you're going to do something about it. That's and now we're going to the proximal stent, and remember there we had really a very big concentric plaque with some cracks in there, and see how the stent is behaved. There
So
it
this is pretty cool. We didn't make an angiogram, and we estimated based on the IVUS the size, and we estimated to land just before this large septal and diagonal branch.
By the way,
which
it's
we managed
nicely
to do
round.
exactly.
Look at the stent, it's nicely round. That means that the calcium gave way. That means that you got the resistance from the calcified plaque with your orbital atherectomy and with your pre-dilatation afterwards. So still good deposition. I'm now curious of the ostium of the LAD because...
It's a tricky part, huh?
Yeah, we have it's partly in the left main.
But
I'll
that's
stop it
okay.
here. Well, it stopped automatically. Now let's have a look. So we see distal. It's well opposed here, but we had some malposition proximal, and I'll give immediately the balloon that if you want to bring this up, we need to have a balloon 3.28. Actually, we anticipated that already, didn't we, Joost? That's the proximal edge. Then the proximal stent, it's in general nice and round and opposed. Only thing, it came a little bit more proximal than maybe intended. And we ended up here in the left main stem, which was, as you said already, it's huge compared to the rest. And for that, you need a sort of pot of 4.75.
So maybe we can quickly show the angiogram before we lose connection. So this is the final angiogram.
Angiogram, beautiful. Yeah, I
so that's
definitely
exactly
would
what we intended to do.
the stent down distally.
Yeah, so there is a small, you see, maybe you don't recognize, you cannot appreciate it that well, but before the very small diagonal at the tip of the radiopaque part, there is something I don't trust very. So I'm not sure I want to be even more aggressive here.
Something like
On the IVUS, we don't see any hematomas or ruptures, but could be a very small covered perforation. Now it's fine, patient is fine.
Here it is. Yeah, just here it is.
But so I think I'm pretty happy. We'll continue with the circ.
Yeah.
And we truly hope we gave you a good impression of what the orbital can add.
This is an incredible, incredible demonstration of orbital atherectomy. Very, very difficult sequential lesions, use of imaging, fantastic work by Erasmus as usual, and a great segue for our breakout session, which is going to be led by Ajay Kirtane on the latest insights on when to use and choose orbital atherectomy. I just can't thank you enough, Nicholas and Azim, for your wonderful comments, Joost for your beautiful team and the work that you guys do and continue to do in Erasmus. Congratulations on this great live case demonstration on a very difficult So thank you all. Thank you, team. Stick around. We have a fantastic breakout session coming to you exactly at 11:15. Thank you all. See you all then. Bye-bye.